Welcome, and thank you for joining us for our Lymphedema and the Cancer Survivor webinar. My name is Roxanne Berger, and I am the Clinical Nurse Coordinator for the Survivorship Program here at MD Anderson Cancer Center at Cooper. I'm excited that everybody has taken time out of their busy schedules to participate today. Now, without further delay, I am happy to introduce you to our presenter, Anna Porch, physical therapist, certified lymphedema therapist here at MD Anderson Cancer Center at Cooper. Anna, welcome.
Thank you. I'm excited to be here to share this presentation with you. I'm going to go ahead and share my screen. All right, I hope that's working. So like Roxanne said, my name is Anna Porch. I am a physical therapist and a certified lymphedema therapist here at MD Anderson Cancer Center at Cooper. I've been in the oncology world for about 7 years now, and I'm excited to share this presentation with you on lymphedema and the cancer survivor. So we'll jump right in. The goals of this presentation are to describe the lymphatic system and lymphedema, to discuss the causes and risk factors for developing lymphedema, and to learn about risk reduction practices, treatment, and discuss the latest research. So to start off, we want to talk about the lymphatic system and get a good knowledge kind of the background of lymphedema. So the lymphatic system is a transport system that brings lymphatic fluid from the tissues to the bloodstream. It runs alongside the arteries and the vein, and it has three main functions. It's a part of the immune system, and it filters out impurities, it transports and creates white blood cells. It balances fluid and proteins in the circulatory system by transporting those proteins and the water, and it aids in fat digestion by absorbing the fat molecules in the small intestine. It comprises of a superficial and a deep system. The superficial system drains the skin and the subcutaneous tissue. That's the tissue that's right underneath the skin. And the deep system helps to drain the muscle tissues, the tendons, the nerves, the joints, and the organs. So in the lymphatic system, the fluid circulates from the tissues to the lymphatic vessels. The lymphatic vessels then send the fluid to the lymph nodes and ultimately back to the venous system. So what is lymph fluid? Lymph fluid is clear fluid that's made of protein, water, cellular components, and fat. Once the interstitial tissue enters the lymphatic system, it's then referred to as lymphatic fluid. Interstitial fluid is just any fluid that's found in the tissues. The lymphatic system, the pathways are much larger than the pathways to the venous system, so it's easier for the larger molecules to enter the lymphatic system than it is the venous system. So the parts of the lymphatic system, there's the lymph nodes that actually filter the lymphatic fluid, the lymph capillaries, which are the transport pathways for the fluid to move from the tissues to the lymph nodes, the tonsils, which are actually the first defense against anything ingested or inhaled, the thymus, which actually develops the T cells, which are a type of white blood cell, and the spleen, which filters to remove old blood cells, make antibodies, and help to remove bacteria. So what are the lymph nodes themselves? Lymph nodes are round, kidney bean-shaped organs. There's usually 600 to 700 throughout the body, but it very much varies person to person. And there's main groups of lymph nodes in the head and neck and the intestines. Both of those help because most pathogens enter the body either through the head or neck region or in the intestines. Both axillas and both groins also have main groups of lymph nodes. They function to filter impurities such as cancer cells, bacteria, viruses, abnormal cells, or any other debris. They help to produce antibodies, and they help to thicken the lymphatic fluid by reabsorbing a significant amount of water. So lymphedema itself, lymphedema is an accumulation of lymphatic fluid in the tissue. It occurs when the lymphatic system is unable to accommodate for the lymphatic load due to an insufficiency. The lymphatic load is the amount of lymph fluid in the lymphatic system. There's three types of insufficiency. There's dynamic, mechanical, and combined. Dynamic insufficiency is the lymphatic load increases beyond the transport capacity of the lymphatic system. So if you think about a road analogy or a construction analogy, this is a regular road, so 95, you're driving down it, but it's right before an Eagles game. So the number of cars on the road is far beyond what is normal. That would be an example similar to dynamic insufficiency. Mechanical insufficiency is when the transport capacity of the lymphatic system is reduced. So there's been damage done to the system. So a 4-lane highway now only has 1 lane open, and that's going to create some congestion even if it's not rush hour. And then combined insufficiency is when the transport capacity has been reduced and the lymphatic load is increased. So that means there's damage to the system, but there's also an increase in the amount of lymphatic fluid. For example, there's construction on the Schuylkill and it's rush hour. That's going to create some issues. So lymphedema itself is very slow and progressive. It only affects the territory in the body where the lymph nodes were removed or damaged. So this picture here on the right, you can see it kind of has the body broken down into different what are called watersheds, and it tells each lymph node group drains those specific areas. Lymphedema is defined as an increase in limb volume greater than 10% or a 2 centimeter difference circumferentially between limbs. It occurs typically greater than 3 months post-treatment, and there is currently no cure for it, but there are treatment options. There's ways to reduce the symptoms and ways to decrease the swelling, and we'll get into that. So what is not lymphedema? Any sudden onset of swelling, any redness, pain, warm to touch, or any swelling immediately after surgery, like in the first 3 months. The first 4 items there could indicate a medical emergency or an infection, so you'd want to contact your doctor if any of those come on. So there's 2 main types of lymphedema, primary lymphedema and secondary lymphedema. Primary lymphedema is due to a developmental abnormality of the lymphatic system. It's typically evident before the age of 35 and often most seen in kids. Secondary lymphedema is caused by damage to the lymphatic system. This is more relevant to the cancer population with lymph node removal, radiation therapy, tumor presence, but then other situations might be trauma, infection, immobility, chronic venous insufficiency, blood clots, and filariasis. As a fun fact, filariasis is actually the most common cause of lymphedema worldwide. It's a tropical disease that affects over 120 million people, and it's caused by parasitic worms that cause dilation and damage to the lymphatic system. But those 3 specific items in the beginning, the lymph node removal, radiation therapy, and tumor presence, those are what's most common to cause or to be the reason why patients after cancer treatment have lymphedema. So now we're going to kind of go through the various types of cancers that are most commonly related to lymphedema due to their disease process and the treatment. It's in no way an exhaustive list, but it's just going to kind of go through the main areas that have been researched. But overall, as just a blanket statement, lymphedema as a whole is still very much a mystery. It's uncertain as to why some people get it, why some people do not. There's a lot we still have left to learn, and even amongst what we do know, there's still a lot of disparity. So just keep that in mind as we're going through things. So specific to breast cancer related lymphedema, the swelling can occur in the arm and the breast or the trunk and the back of the affected side. The prevalence is anywhere between 14 to 40% of breast cancer survivors that develop lymphedema, but it is also one of the most variable numbers in the research, with a very large range present. Typically, you see about 20 to 30% in the research, but it's, like I said, it's very variable. The risk factors for lymphedema after breast cancer treatment. The risk increases the amount of treatment the patient had. So a sentinel node biopsy runs a lower risk of lymphedema than an axillary node dissection without radiation, and then that runs a lower risk than an axillary node dissection with radiation. The number of nodes removed also can increase the risk of lymphedema, but in no means does that say that less than a certain number of nodes you are not at risk. But again, this number is also variable in the research, anywhere from 5 to 8 to 10. It's variable, but again, that does not mean if you've had less than 5 lymph nodes removed, you are not at risk for lymphedema. It just means you might be at a lower risk. Infection and obesity are also 2 huge factors in increasing someone's risk of lymphedema after breast cancer treatment. So lymphedema has been best studied and documented in breast cancer survivors but in no way, shape, or form is it disease specific. And you'll see in this slide, it's actually very prevalent in many other cancer types. So for head and neck cancer, lymphedema can be both internal, external, or both. External lymphedema is swelling of the face and the neck. Internal lymphedema is swelling of the larynx and the pharynx and the internal structures, or it can be both. External lymphedema is swelling of the face and the neck. Internal lymphedema is swelling of the larynx, pharynx, and internal structures. Very rarely, external lymphedema is present without an internal lymphedema component. Lymphedema of the head and neck tends to be a little more significant. If you think about what you need your head and neck for, you need it for breathing, you need it for eating. So it tends to affect more of the vital functions of life. And it also affects quality of life a lot more than cancer or lymphedema of other areas. However, for head and neck lymphedema, it is more likely to spontaneously resolve without treatment. There is very little research on it. Not only is the research very limited, but it's very hard to quantify and standardize the measurements for head and neck lymphedema, as well as to distinguish between post-op lymphedema and post-op edema. Most reports of lymphedema in head and neck cancer population has been physician reported. So it kind of brings up the question of involving a lymphedema therapist in diagnosis and treatment. Prevalence for head and neck lymphedema is 70 to 85% of head and neck survivors. That's based on articles published in the United States. Many European articles actually have prevalence rates that are much lower. But as I said before, it's hard to kind of compare because there is no consistency in the evaluation process, the diagnosis process, or anything of that sort for head and neck lymphedema. Risk factors include age, a higher BMI. So these articles had 25 as the cutoff for BMI, radiation, and number of nodes removed. So melanoma actually is another cancer type that lymphedema is common with, because treatment often includes sentinel or therapeutic dissection of axillary or inguinal nodes. There is little consistency in the research, and overall there's just very little research. The cutoffs, surgical procedures, the consistency on how the lymphedema is diagnosed, all of that tends to be a little hazy in the research. Prevalence is estimated to be anywhere between 20 to 23% of patients who had a limb volume of change of greater than 5%. So typically we say for lymphedema, it should be greater than 10%. So that kind of makes it a little difficult to determine what is actually going on. Risk factors, again, different articles track different risk factors. So it was kind of hard to combine them all, but just to give an idea, inguinal lymph node dissections tend to run a greater risk of lymphedema versus an axillary node dissection specific to the melanoma cancer population. But overall, radiation is not as commonly used as a treatment. So that's what kind of separates it from breast cancer and then gynecological cancers. Peripheral vascular disease also increases the risk of lymphedema after melanoma surgery. Post-op seroma and surgical site infection, those two tend to go hand in hand. Usually one causes the other and vice versa. And they often occur after inguinal lymph node dissections, less often axillary lymph node dissections. And then obesity is also a risk factor. This study actually used a BMI of greater than 35, so that's a lot higher than the prior studies, as I talked about before. But the cutoffs are very inconsistent throughout the literature. So then to touch on gynecological cancers, treatment typically involves removal of pelvic, periaortic, or inguinal lymph nodes, and often there is radiation involved as well. But there is limited research. Prevalence is thought to be anywhere from 20 to 27% after surgical removal of pelvic and periaortic lymph nodes. Similar to the other types of cancers aside from breast cancer, there's very limited research. Some of the studies that I was reading had like transient recovery of the lymphedema, which makes me wonder if it was even lymphedema to begin with. Most of the patients that were considered to have lymphedema were actually self-reported, so it wasn't actually diagnosed by a lymphedema therapist. Risk factors were identified as obesity, insufficient physical activity levels, radiation, and the extent of the lymph node removal. To touch on genitourinary cancer, there's very little research, but most lymphedema cases were related to prostate cancer with a lymph node removal and with radiation, but it was a relatively low incidence. By no means does that mean you're not at risk for lymphedema, but just overall there wasn't too many reported cases. One of the main risk factors for lymphedema that you see, regardless of cancer type, was obesity. So just to touch on, excuse me, just to touch on obesity and lymphedema, typically in a BMI of greater than 25 or 30 increases one's risk of lymphedema. Some research found BMI over 30, you're actually twice as likely to develop lymphedema. It's unsure exactly why, but there's multiple hypotheses, one being obesity decreases your lymphatic function because essentially it creates an increased strain and overuse of the lymphatic system, and there's further distance between the intercellular fluid and the lymphatic vessels, so it's harder for the vessels to reach that extra fluid to help it get removed. It also decreases the adipose tissue clearance of macromolecules. It increases lymphatic stress. It exacerbates the inflammatory response, and it also complicates surgical time, procedure, process, and prolongs your surgical healing time. So as I mentioned in the slides before, oftentimes infection post-surgery increase your risk of lymphedema as well. So stages of lymphedema, there's 4 stages. Stage 0 is considered the latent stage when there's no swelling, but there has been damage to the system. Stage 1 is considered the reversible stage, where swelling is present sometimes, but it's usually a small amount, and it might fluctuate. It might be something you notice one day after a long day at work, and then it goes away overnight and you don't notice it again for a couple days. Like I said, it tends to fluctuate. The tissues are soft. You may get a little fingerprint indentation, you may not. And elevation may help, but it also may not. It typically begins in the lower part of the limb. So if your arm is at risk, it's going to typically, like I said, it's going to typically begin in your hand or the lower part of your wrist. If your leg is at risk, it's going to begin in that ankle or that foot. However, this is not always the case, but that is the typical presentation of lymphedema. Excuse me one second. This is how I know I talk too much. So stage 2 lymphedema is considered the spontaneously irreversible stage. It's characterized by hardening of the tissue, more pronounced swelling. And this is when if you use your finger to push into that area of tissue, your fingerprint will stay. There's not going to be a significant change with elevation. It may help a little bit, but it's not going to resolve it at all. And then stage 3 is what's considered lymphostatic elephantiasis. And that's when there's tissue changes from having that consistent swelling, such as blisters, breaks in the skin, thickening of the skin, sorry, significant hardening of the tissue, and infections tend to be very common once you have stage 3. So one thing to keep in mind is lymphedema always progresses through the stages. It does not skip stages. So you'll never wake up with stage 3 lymphedema if you didn't have any swelling before that. That being said, some lymphedema also stops at certain stages. It doesn't always progress to stage 3. I've had plenty of patients that have had stage 1 lymphedema for 20 plus years and it's stable. Like I said, lymphedema is very much a mystery. So the signs and symptoms of lymphedema. Now this is like stage 1 when you actually start to have some swelling. The extremity is swollen. You'll have aching, tingling, sorry, I don't know what's going on. Discomfort at the area at risk. It's typically not painful. It may be like an aching pain, but typically it's not something that causes severe pain. You'll notice tighter fitting clothes, jewelry. Like I said before, your indent stays in the skin with pressure, and you might feel some fullness or heaviness in the area at risk. So in order to diagnose lymphedema, it's important to obtain an extensive history to determine the cause of the swelling, a comprehensive physical examination to make sure the swelling isn't caused by anything else that might need to be addressed medically, circumferential measurements, which are typically taken by a lymphedema therapist to determine the volume change. Perimetry or volumetric measurements are different machines, different equipment that is used based on the facility, not always available. There's many different tools actually that can be used for diagnosis, including bioimpedance spectroscopy, DEXA, lymphoscintigraphy, sorry, but they're not always necessarily readily available. And ultimately, palpation, observation, and examination by a certified lymphedema therapist is going to be your best bet for diagnosis. And then to get into treatment for lymphedema. Stage 0, where you're at risk for lymphedema, the most important thing is just education on lymphedema, the signs, the risk factors, risk reduction practices, kind of what we're going through right now is pretty much a little bit expanded version, but this is what I would be teaching my patients if they had stage 0 lymphedema. Stage 1, once you start to notice that swelling, sorry, is when we would help you obtain a compression garment. Typically, these are pre-made off the shelf. Elevation if possible, if the swelling does respond to it. We would teach you a self-MLD technique, which we'll get into MLD in a little bit, and decongestive exercises, just to keep that swelling moving and hopefully get it out of the system. If the swelling progresses to stage 2 and stage 3, that's when we're going to start doing something called CDT, complete decongestive therapy. There are treatment options for lymphedema we'll talk about in a little bit, but CDT is considered the gold standard currently, and still, it's held up for quite a while. So complete decongestive therapy, there's 2 phases. There's the intensive phase, which is the treatment phase, when we're trying to get all that swelling out of the limb. And then there's the maintenance phase, which is once the swelling has been optimized, and then the patient is sent home to maintain on their own. The intensive phase is actually very intensive. The ideal is for therapy visits 4 to 5 times a week. Typically, it takes about 3 to 5 weeks per each limb to fully decongest. And there's 4 components. There's manual lymph drainage, compression bandaging, skin care, and decongestive exercises. Once that swelling has been resolved, then we hit the maintenance phase, where it's home management that basically just involves good skin care, exercise, and the wearing of a compression garment. So we're going to delve a little deeper into complete decongestive therapy and the different components of it. So manual lymph drainage should be performed by a certified lymphedema therapist. It doesn't necessarily have to be a physical therapist. Occupational therapists, massage therapists, speech therapists are all eligible for this certification. It's a stretching technique that stimulates lymphatic contractility, and it enhances lymphatic drainage. So the technique is simple. It's a light stretch to the lymphatic vessels to stimulate and direct the flow of the excess lymph in the direction that we want it to go, which is up and out of the limb. It's most effective when it's combined with compression bandaging. So compression bandaging, like I said before, should be used in conjunction with MLD, manual lymph drainage. We use multi-layer short stretch compression bandages, and we use foam inserts to create a cone shape for the limb. It's based off of something called the law of Laplace, which gets into physics, which says that if the radius of a cylinder is increased, the tension needs to be increased as well to achieve the same pressure. So how that translates to compression bandaging is that if the compression is applied in a consistent tension to a cylinder, the pressure will be greatest where the radius is smallest. So that's going to help us get the most compression furthest from the body and the least compression closest to the body. So that's going to help to direct the flow of the lymphatic fluid back to the groups of the lymph nodes, which can ultimately filter it out. And then along with the MLD and the compression bandaging, it's important to maintain good skin care during CDT, moisturizing, cleansing the skin, avoiding any burns, breakdown, cuts, bites, and to watch out for any infection that might be happening. Exercise, which we're going to get into a little bit more detail of. The muscle pump is great to increase circulation and lymphatic flow. So it's important that we have our patients exercise while they are undergoing CDT. It will not increase the risk of lymphedema. It's actually going to help enhance the treatment. So lymphedema and exercise, this is kind of a big area that's growing right now. A bunch of research has just been done, especially at the University of Pennsylvania. They had a huge trial talking about the safety of exercise if someone's at risk for lymphedema. And ultimately it was found that yes, exercise, specifically resistive exercise, is very safe for anyone at risk for lymphedema as long as it's performed properly. So just some guidelines for exercise if you are at risk for lymphedema is to ensure clearance by your medical team. You want to progress slow. You want to begin without weights and increase in the lowest possible increments. And you only want to increase weights when the exercises can be performed for multiple sessions without difficulty. So it takes a little changing of the mindset. You don't want to do like arm day, leg day. You don't want to just burn out a specific muscle group. So you do want to alternate muscle groups within that singular workout session. And anytime you have an exercise holiday, so a break, a couple days to a week or two, you want to decrease the weight and start a little bit lower than you were before. And with any increase in your symptoms, you want to make sure you stop and contact a medical professional. And then compression garments, which I had talked about, are a huge part of the maintenance phase. Lymphedema-specific compression garments have a graduated compression. So like we talked about with the law of Laplace, you want to have the most compression furthest from the trunk and the least compression closest to the trunk. And that's going to help to direct the fluid in the direction that we want it to go. They should be replaced about every 6 months with consistent wear. For stage 0 and stage 1, they're going to be used more as a prophylactic if the patient's at high risk for developing lymphedema. And they're typically off-the-shelf, pre-made garments. For stage 2 and stage 3, we're going to transition to compression garments once we've completed CDT. So once we've gotten the maximal reduction in swelling of the limb. And typically these garments are custom made. Not always, but typically that's going to get the best compression to maintain that reduction in swelling. So some other treatments that there are for lymphedema, one of them being a pneumatic compression pump. What they function to do is attempt to replicate manual lymph drainage. They're sometimes used during the maintenance phase. The efficiency is a little bit questionable because they actually may lead to worsening fibrosis, which is hardening of the tissue. But in no way, shape, or form should they ever be used as a replacement for CDT. They're really great to be used in conjunction or as a maintenance tool like I talked about. But you should have probably at least trialed CDT before a pneumatic compression pump is being used. Kinesiotaping is an effective treatment for small areas of swelling and for very early stages of lymphedema. It's not really anything that we would use stage 2 or stage 3. Laser therapy is kind of coming out in the research a little bit more. Laser therapy helps to decrease inflammation and promote cellular healing. The effectiveness is inconsistent throughout the research. Most articles say it has a success rate of helping lymphedema about 33%. So it's an option to use, but again, CDT is maintained as the gold standard. And then in terms of surgical techniques, currently lymph node transfers and lymphovenous bypasses are kind of up and coming, so to say. They're in the very early stages of use. They require months of CDT treatment, and once that has failed, then that's when the plastic surgeons or the vascular surgeons would look at doing these transfers or the bypasses. Liposuction is also sometimes used to reduce lymphedema. However, liposuction is a very just get what you can procedure. So sometimes that also takes out healthy lymphatics. And sometimes the side effects of liposuction are actually lymphedema. So it's not always the best treatment option. And debulking is a surgery to remove the actual tissue that is lymphatic, that has lymphedema. It's often very disfiguring, and it often leads to greater lymphedema in the areas that were not debulked. Diuretics typically are prescribed for patients with lymphedema off the bat, but they're typically not effective because, as we talked about, lymphedema is like a protein-rich fluid, and diuretics help to remove water. So once the water is removed, then the proteins have nothing to kind of carry them out. There are many new treatments currently in the preclinical stages, so there's no research on, but I know there's medications, there's stem cell therapies, genetic molecular therapies. There's a lot of things kind of coming down the pike, so stay tuned. And then to kind of wrap it up a little bit, we're just going to talk about risk reduction practices. Sorry. These are guidelines that are provided by the National Lymphedema Network. I have my little salt shaker there because I always tell everybody to take these with a grain of salt. There's no 100% way to prevent lymphedema if there's been damage to your lymphatic system. There's no way to prove necessarily that these behaviors will cause lymphedema, but it's kind of a compilation of common sense practices, so to say, that the NLN has published. There are risk factors that do increase your risk, like we talked about before with obesity, infection, things like that. But these practices, I always tell my patients, you can do everything right and you can still get lymphedema, and you can do everything wrong and not get it. Lymphedema, like I said, is still very much a mystery, but these are kind of some guidelines to go by just to help minimize the risk if possible. So exercise is excellent, like we talked about with the muscle pump and facilitating lymphatic flow. You want to make sure you're taking good care of your skin, preventing any openings in the skin, avoiding any irritations or burns. So basically all functioning for infection prevention. You want to avoid anything that can cause infection, keep your skin moist, treat any breaks in the skin, and know the signs and symptoms of infection. So yeah, if you have redness, pain, warmth, swelling, if you run feverish, those are the kind of things you want to call your doctor to get on antibiotics as soon as possible. Weight control, weight loss, like we talked about, weight loss or obesity tends to be a risk factor for lymphedema, regardless of cancer type. So maintaining good weight control is important. Avoiding overuse. So overuse can be like repetitive use of or repetitive movements of heavy objects, or suddenly using the limbs for things you haven't used before. So that kind of stems back to the lymphedema and exercise slide. You want to avoid prolonged heat or cold, avoid restrictive jewelry or clothing, anything that might create like a tourniquet effect to that limb. And overall, you just want to avoid any trauma to the limb. Trauma can be those repetitive movements or repetitive trauma, and that's kind of where it stems when people say don't get any blood draws, blood pressures, or injections on that side at risk if you're able. Oop. There you go. So in parting, just like cancer, everyone's lymphedema journey is very different. Lymphedema presents differently, and lymphedema can be treated differently based on each patient, based on each patient's needs. You in no way, shape, or form are alone. This presentation is not to scare you, but it's to educate you, but it's also to let you know how common lymphedema actually is. Education is the most important component. I always tell my patients, I do not want you going out into the world, wrapping your arm or wrapping your leg in a bunch of bubble wraps and, not using it ever again. Education is the most important, and just knowing the signs and symptoms to look for. Be aware of ways to reduce your risk. Treatment is most effective when it is caught early. So that's why knowing the early stages and the early signs is important, so you can talk to your doctor. And therefore, talk to your doctor if you have any concerns. If you do think you have lymphedema, the first step should be to contact your doctor. They're going to have to do a little bit of a medical clearance and just to make sure there's nothing else that's more at risk, more risky going on. And then we have 3 lymphedema therapists here at Cooper. I am located here in Camden. And then we have Carrie and Melissa who are located at our Voorhees offices. You'll need a script from your doctor, so therefore you have to contact them first anyway. And then you would schedule with us here. So these are some references that I used, and then we'll open up to questions. And I'll chug some water.
Hi, thank you, Anna. I'm so sorry you were having a little trouble there, but you did wonderful. You did great. So we have several participants have asked a couple questions, and so we'll start with the first one. Susan had asked, what is the success rate of therapy for patients that develop lymphedema?
So it's hard to put a set number on it. And I don't mean this in a bragging way, but I've never had a patient not respond to lymphedema therapy.
Okay. How many years should a compression sleeve be worn?
So if you're wearing compression sleeves as a preventative measure because you are at risk for lymphedema, again, I don't want to give too much clinical advice because that is something you want to talk, it's case by case. But if you're wearing a compression sleeve, but you have no swelling and you're just wearing it for risk reduction, essentially your risk for lymphedema never goes away throughout your lifetime. Your lymph nodes were removed, your lymphatic system was damaged. And while the lymphatic vessels themselves will heal and will create new pathways, your lymph nodes will not grow back. So if you are wearing a compression sleeve as a preventative measure, that's something that you want to maintain essentially forever. If you're wearing a compression sleeve because you had lymphedema and had treatment for it, and then this is the maintenance phase, then you're going to want to wear a compression garment 24/7 forever as well.
Okay, so speaking about the removal, I have a couple questions. One of the participants said they had 2 lymph nodes removed. Can lymphedema occur at any time? I have another patient who's been out 10 years and they don't show any signs or symptoms currently, and they wanted to know, is their risk reduced being that time has gone by?
Those are very good questions, and they're very tricky, unfortunately. Like I said before, number of lymph nodes removed, even if you've had one, you still have a risk of lymphedema. In theory, your risk is going to increase the more lymph nodes removed. But that does not mean you need a compression sleeve. It does not mean you need to be doing anything specific. It just means it's important to know about lymphedema. So if you notice swelling one day and, a little bit in your hand, then you would say, oh, wait a second, it's going to jog your mind, as opposed to, unfortunately, many people who've never even heard of lymphedema, they wouldn't think of that as a question. In terms of years out from surgery, years out from, damage to your system from cancer treatment, it goes back and forth amongst therapists and amongst the lymphatic world. So some people will say, oh, if you haven't had it within 3 years, you're kind of out of the woods. Like I said, they don't know why some people get lymphedema and some don't. So I think the assumption is within that 3 years, you would have gotten it if you were at risk, if your genetics or if something about your body is going to give you lymphedema. That being said, like I said before, your lymph nodes never grow back. Your lymphatic system does create new channels and it does heal a little bit, but your lymph nodes have never gone back. So I always tell my patients, you're never really not at risk for lymphedema.
The garments that for your extremities, can they be worn at night?
So it depends on the type of garment you have. So that's something you need to talk to your specific therapist about.
I'm sorry, my throat is starting to bother me. Are there any exercises that you could recommend for people who are at risk but don't actually have lymphedema at this time?
So again, I don't want to get into giving too much clinical advice because you would want to see a therapist at that time. But in terms of exercise specific to reduce your risk of lymphedema, there's nothing specific as kind of as a key. Just exercise. Doing any kind of exercise is going to increase that muscle pump. It's going to increase circulation, specific especially to that area that you are at risk. You can get specific exercises, yes, based on the area at risk, but usually that's not as important unless you have had swelling or unless you have swelling currently. In terms of you've had lymph nodes removed, but everything looks good, just maintaining an active lifestyle, maintaining activity with all limbs, but especially with that limb that's at risk is important. I hope that answers the question.
So with somebody, as far as risk reductions, if you already or have been diagnosed with lymphedema, would losing weight help with that situation?
Yes. So I have had multiple patients that they have lymphedema and it has nothing, well, it probably they might have gotten it because they had obesity, but they have lost weight and it significantly decreases the swelling that they have in their arm or their leg, whichever limb is affected. So as a preventative measure, if you have obesity and you are at risk for lymphedema, that's one of the best ways to reduce your risk is to lose weight.
Oh, okay. All right. Do we have any other questions in the audience? Any other questions? So I do have one more. It says the person has not had any lymph nodes removed. Are they still at risk for developing lymphedema?
So if you have not had lymph nodes removed, there are other things that will put you at risk, cancer specific, depending on the location of the tumor. That sometimes can compress the lymphatic system, or sometimes it's somehow entangled in the group of lymph nodes. That's again, patient specific. And also radiation can increase your risk of lymphedema in terms of cancer treatments and things like that. Outside of the cancer world, there are a bunch of reasons that you might have lymphedema. But in terms of actually putting you at risk, it would only be if you've had that trauma to your body or you've had those other things that put you at risk.
This question is a little bit more specific. This participant was talking about upper thigh swelling and says that their compression sock doesn't work up there. Would you recommend anything, or should they go back to their therapist?
I would recommend go see your therapist. The leg is always a very tricky body part to wrap and to get to maintain the compression garment on. But there are a variety of different options to try. The leg tends to be a puzzle as to what works best. So I would go back to your therapist and kind of talk about other options.
Okay. Do we have any other questions? I'm going to open it up and unmute. So if anybody would like to share, Anna, talk about the wonderful facility we're opening in Camden. Yes, I almost forgot about that.
So my baby will be opening hopefully soon. I think tentatively it's slated for April. Right now I'm operating out of this tiny little room here. On the 4th floor of the MD Anderson building in Camden. We're going to be opening a facility that's going to, it'll be open for all lymphedema patients. So I'll be treating lymphedema there, but also we'll be opening up to all oncology rehabilitation needs. We'll have speech therapy, occupational therapy, and physical therapy there. And it's beautiful. And it'll be opening soon.
Does anybody have any questions? The attendees can unmute yourself if you have any specific questions you'd like to ask or share a story.
Hi, my name is Tamara. I was calling. I have a question because I'm on hydrochlorothiazide for my blood pressure. Will that increase my risk for lymphedema? I had 18 lymph nodes removed because of breast cancer, and my arm does feel like my underarm, but I'm still right off of surgery. I had it 4 weeks ago. So it still feels a little swollen and stuff sometimes.
Yeah, so medication itself won't increase your risk of lymphedema. And it's very common that soon after surgery to have that heaviness kind of in that armpit area. In theory, no medication should increase your risk necessarily.
Thank you.
You're welcome.
Thank you. Anyone else?
Yes. Hi, Anna.
Hello.
I put a question on the chat board, but I guess you guys didn't notice it. So I was diagnosed with lymphedema 4 months after my surgery. I had 13 lymph nodes removed from my neck. And I went to, a physical therapist and had lymphedema therapy done on my neck. Then I had to switch insurance companies, and I wasn't able to go to that particular therapist, so I went to another one. And then I've just had another one recently, once again, because of insurance changes. Everyone had a different technique. There's no right. I don't get it.
Yeah, and especially, I don't know. You kind of indicated it might have been a head and neck cancer.
Yes, it is. In my neck here. Yeah.
Yeah.
Apparently, this is where the lymphedema is, in this area right here.
Okay. Yeah, specific to head and neck cancer, it's a very variable world. It unfortunately, like as you saw with the numbers, I was reading the articles, and it requires actually not a different certification, but a different class and all of this stuff. And I was reading the articles, and I talked to our speech therapist who deals with usually the motor part of the issues that come after all those surgeries. And I was saying to him, like, I can't believe this is 75 to 80% of everybody. There's no way. But it's just a very under-researched, and again, it's very hard to figure out measurements. It's very hard to figure out garments. It's very hard to kind of get that standardized practice because treatment, and because the treatments for the head and neck are very different, and so then the presentations are very different. And it does depend. I mean, and it does depend for arm and legs too. It's not necessarily just head and neck, but head and neck, you'll notice a lot more variability because there has been that difficulty standardizing assessment, standardizing treatment, standardizing kind of the methods for treatment. Sorry, it's not a good answer, but.
Yeah, I'm blown away by the different approaches, you know, for pretty much the same thing. And I'm like, what should I try a different? Well, like, I haven't tried you guys yet. I've been to NovaCare, Jefferson, Virtua. All right, well, thanks for trying.
Please feel free to contact your doctor so you can get an order, and we can get you set up with an appointment. Right, Anna?
Sure. Come on down.
Flying. Can that affect whether you need to wear a sleeve or not, Anna, when you fly?
Yeah, so this is a hot topic lately. There's actually been nothing to prove that flying does lymphedema. It was always encouraged as a prevention practice to wear a compression sleeve as you're flying. But again, there hasn't really been any research saying, yes, it definitely causes lymphedema, or really anything telling us one way or the other. A lot of the risk reduction practices, it's hard to, I guess, prove is the right word, because ethically, we're not going to do something to a patient that might put them at risk for lymphedema just to see if it does. So that's why I kind of stress them as common sense practices. I would advise you, if you feel comfortable with it, or if you normally fly and notice you have swelling. I know, you know, like a lot of people wear compression garments and stuff just for, you know, to prevent swelling in their legs. If that normally happens to you, it probably wouldn't be a bad idea to wear compression if you are at risk for lymphedema. But again, it's taking it all with a grain of salt, because that actually hasn't been, there's been nothing proving that, yes, that will cause lymphedema.
Anna, is your screen still shared? Because some people would like your name and the names of the other therapists. Can you go back to that slide? There you go, everyone. Okay, so, high impact exercise. One of our participants, they tennis. They do tennis. Is that considered an overuse, or can high impact exercise affect lymphedema in the limbs?
Nope. So there is no necessarily restriction on exercise, what type, what form, or anything like that if you're at risk for lymphedema. But it's important to, if you look at the lymphedema and exercise slide, to build up slowly. So if you haven't played tennis and then you go play for an hour, that's going to be overuse. But if you have been playing tennis consistently, or you know, you did 10 minutes last week, and then you did that for 3 days, and then you did 15 minutes this week for 3 days, and then 20 minutes the next week, you want to slow up. Someone's doing it. Oh, there we go. I hope that answers the question.
One more, CD oil and supplements. Do they help with lymphedema?
I don't know. I'll be very honest. I don't know. I have patients who've tried them, and there's no research out there, and I like to kind of stick to that when it comes to new things. But yeah, there hasn't really been anything out there saying yes or no.
I have a question.
Yep.
I had heard that you have to protect yourself from the sun. Is sunscreen good enough, or should I keep my arm covered with, say, just a towel or a long sleeve shirt or something?
Sunscreen's perfectly fine. Just obviously making sure you're reapplying and really protect, you know, making sure you cover every area. Sunscreen's good just in general.
Right.
But I always like to say, just be very aware, because the last thing you want is for that limb to get sunburned, because burning when you have a sunburn, that causes swelling in your body, and you're now causing swelling to an area that might not be able to get rid of it as easily as normal.
Right. Thank you.
No problem.
I have a question about the textile medical pump
Mm-hmm.
I received a couple months ago. It seems like it's working a little, but is that going to reduce the swelling? Like, I have it in my leg.
Okay, so usually we recommend the compression pumps be used like as long as you've tried the lymphedema therapy and you have compression garments, because the pump is going to be, you know, fairly effective. It's going to help to get the lymphatic fluid moving. But once you come out of that pump, if you don't have any compression on it or you don't have anything to kind of keep things together, then that swelling can come right back. So
You're
that's where you want to
absolutely
make sure
right.
you have, you want to make sure you have kind of multiple aspects to it. It's not, you know, it can't be used solely as a treatment.
Yeah, because sometimes before bed, if I do it, I don't put the garment on, but my therapist said, look into sleep garments. Like there was one that was quilted out there. I don't know, like sometimes the insurance company, now that I'm on Medicare, it's like they don't pay for a lot of the, well, they
Yes.
pay for the therapy, but only so many sessions. Like I would love to go more than once a week, but I don't think they would pay for that.
Yeah, unfortunately, something that kind of the bearer of bad news for all of this is insurance, and private insurance tends to pay a little bit better than Medicare in terms of the garments themselves. Typically, they pay for the actual session, like you said. A lot of the outside stuff that makes it a little bit of a challenge. Thankfully, you know, breast cancer specifically, it's gotten a lot more publicity, so that kind of helps bring lymphedema to the forefront. So there are actually a lot of bills in Congress or down in Washington, D.C. right now that are trying to fight for improved insurance coverage for compression garments for patients with lymphedema. So if anybody who's out there, the Learn Network and the National Lymphedema Network, those are two very strong advocacy groups. So they have, you know, petitions and things like that that you can sign to try and help kind of fight for that a little bit, because that's the worst part of my job, is telling patients that, you know, insurance doesn't cover these things.
I think having the stars, like some of the famous people that have lymphedema helps too with getting this out there.
Kathy Bates has been great in the lymphedema world.
Yeah, she's really good.
Anna,
Yeah.
there's one question about hypothyroidism and lymphedema connection. Is there a connection?
There's a lot of reverberation, but I think you said hypothyroidism. So there's a lot of various medical conditions that sometimes can lead to lymphedema, or lymphedema is commonly seen with if a patient has no other risk factors. I wouldn't necessarily say hypothyroidism is commonly related to lymphedema, but sometimes there are reasons that it might be related. I don't know if that's a good answer or not, but there's a lot of different medical conditions. If somebody comes in to see me, they have no cancer history, nothing like that, but they have these other medical conditions that sometimes create extra swelling in the body or create obesity or add to other issues that could be a factor in it. But if someone, you know, off the streets just said, I have hypothyroidism, is this lymphedema? It wouldn't be an automatic relation, if that makes sense.
One last quick question, and you might know this or not. Does Cooper offer any group exercises or weight reduction, like videos or virtual presentations in the age of COVID?
I don't know about like specific to weight reduction. I know we have a couple things coming down the pike in terms of like cancer related exercise. I know the survivorship committee, they do offer some classes. I don't know what's going on with COVID right now, but I know in the coming times there will be more and more offered specific to these populations.
the survivorship program is working on finding a facilitator to lead. And once we find that, we will be offering virtual classes online for our cancer survivors. Well,
It's
our
hard to
time
find
has
them.
gone by really quickly. Oh, one more question. Can the affected area exhibit burning sensation?
So yes, sometimes, depending on what surgical procedures you had done or anything like that, burning tends to be a little more related to nerves things, but lymphedema can kind of aggravate that, yes,
Okay.
but not always.
Okay.
There's a lot of therapists out there as well.
Say that again.
I find that there's not a lot of therapists, lymphedema therapists out there.
That is correct. There are not too many of us.
You guys are really gold standard. It's hard to find you.
Yeah, we're actually, believe it or not, we're very lucky living in this area, like the Philadelphia area and suburban areas around it. We're not inundated with them by any means, but there's a lot of patients in a lot of areas of the world that are traveling, or not the world, the United States, that are traveling 2+ hours to get to the closest lymphedema therapist.
Wow.
Yeah.
It's amazing. Yeah. And they say that there's more people with lymphedema than AIDS and a lot of other diseases out there, and there's not a lot of hype yet on it.
Well, like I said, worldwide, there's lymphedema is caused by a lot of other things. Filariasis specifically, that tends to be in tropical, lower income, third world countries. And so a lot of treatments for it tend to be groups from the United States or groups from Europe who travel out there to help as best we can. But yeah.